A very good afternoon. For today's grand round on behalf of Department of Surgical Oncology, we are going to share our experience of computerized database development in the field of oncology. It's almost a 2-decade journey. We started in 1997, sometime 97. So now most of the databases are mature. So we thought we'll share our experience with all the faculty of AIIMS, faculty and students. As you all know, the last 3 decades, there's a major transformation of global healthcare. Scenario. Now we are in the era of evidence-based medicine. Convergence of informatics science, computer science, and health science has led to the birth of health informatics, the new field, which is otherwise known as medical informatics, bioinformatics, or health informatics. What exactly it means is it deals with the resources, devices, and methods related to acquisition, storage, retrieval, and use of health-related information. That's what we are involved in day-to-day practice. So just to familiarize the nomenclature, we are in the era of health informatics systems. HIS is health informatics system, EMR is electronic medical records, EHR is electronic health records. So these are used in different contexts. The hospital management is more interested in the health informatics system. Insurance companies will have some other interests. But as a clinician, what we are interested in the clinical informatics. That is what we will be stressing today. There are different HIS systems for imaging, which includes PACS, hospital informatics, and bioinformatics. Clinical informatics, the use of healthcare information by clinicians. The clinical information by the clinician with the capability to use the medical and bioinformatics knowledge. He should take a lead, design, implement, evaluate, and analyze health informatics data, which you see in day-to-day practice, along with IT professionals to improve healthcare outcomes, facilitate clinical research, and promote evidence-based medicine. So what is the need for a clinical database? For a government or a scientific organizations, we need to estimate the magnitude of disease burden, epidemiological trends. It is useful for policy and planning, resource allocation, and human resource development. But for clinicians like us and hospitals like AIIMS, so what is the need for a database? So we have huge number of patients we treat, but unless you capture this data in a systematic, structured manner, entire data goes waste. It cannot be used for any clinical research or collaborative research. So you can, if you capture them, you can have a disease profile evaluation, patient profile evaluation, treatment patterns, outcomes. All these things will lead to improve the quality of care based on the census, morbidity, mortality, survival analysis. You can do various sorts of analysis and create new clinical pathways. And last but not the least, our mandate is research and publications. For AIIMS, these two are one of the major mandates for all the clinicians. You all know the problems with paper-based medical record system. Even if you have a brilliant idea, you spend a lot of time in gathering numbers, going to medical records, gathering files. You end up maybe picking up 25, 20, if you're lucky, maybe 50% of the files, and the data is extremely disorganized. And it leads to waste of energy, enthusiasm, and often sometimes you end up doing data cooking. You start with data mining, but you end up doing data cooking. So this is what happens. So the key message is there is a need for clinical database. Data entry in a standard, systematic, structured, and scientific format. It's extremely important. We write according to our whims and fancies in a paper files. There are abbreviations, there are language issues, the multiple issues which cannot be analyzed. So in the database, what you need to do is you have to create a database using standard, systematic, structured, scientific format. Data should be suitable for coding and analysis. We should be able to interpret and effective utilization of the data. It should improve clinical outcomes, leading to research and publications. How to plan? When idea comes, how to plan a database? You need to look at the architecture and design of the database. You need to have a big vision, what exactly you want in the next 20, 30 years. Organizational alignment, you should be able to align with the organization where you are working. You cannot work in isolation. Operational management is extremely important. How to maintain, starting is very easy. Maintaining it for 20 years is extremely difficult. And how to manage the data, how to manage day-to-day operations. We always think if you want to computerize AIIMS or something, we think it is the job of computer facility or ITs. It is not true. For a clinical database, clinician is the core member. 80% of the inputs has to come from clinician. I want these fields, I want this information in my database. Hospital database, medical records are different. Clinical database is purely scientific structured database. So the computer experts can contribute maybe 10 to 20%. Clinician is the core member. Well, and where to develop a database? We are struggling in AIIMS for last 20, 30 years. Computerization, committees, so many things have happened, but we have realized it's not possible in a complex system like AIIMS to have a uniform database system, clinical informatics, to integrate when you are dealing with 50 different specialties and 10 different centers. So it can be done at a new hospital, it can be done at a center, it can be done at a department level, it can be done at a unit level. If this is not possible, at least do it at a faculty level. So this is the beauty of the system, because you have huge number of patients. If you have all the facilities, everything aligned, you can start the paperless hospital from day one. Then center, then department, then individual. Don't waste your time, don't wait for computerization. So we started at our unit level. So how to plan a database? You need to plan thoroughly. We spent 2 years before we started this database. You need to identify your clinical team and IT team. Define your clinical database needs, what exactly you want from this database. What are the fields I'm going to create for this particular cancer, and what are the outputs I need. You need to define everything. Define the architecture of the database, layout of the database, prepare database modules, data sheets, output requirements, what outputs you want, quality control, how to maintain quality, hardware and software requirements. Otherwise, what happens is, if you put garbage in the computer, garbage will come out. This is called Gigo phenomena. So you have to be very clear what you want to capture. So we started with blank papers, preliminary drafts, revisions, fine tuning, digital drafts, dummy entries. Then we reached the stage of final computerized entries. Oncology is a complex field. It deals with multiple organ systems and different cancers. It is not easy to create a single database which caters to all cancer patients. So you have to be very clear what you want in this database. You can have a general clinical database catering to common fields of cancer patients, and for disease and organ specific, you create a specific databases for each cancer. And these databases should not be too exhaustive. It should be user friendly and capture all relevant information with the clinician needs. Suppose for a breast cancer, you want to capture the location of the tumor, type of surgery. You should be able to code these procedures, which location 1, 2, 3, 4, 5. So the user does not have to spend or write anything. He needs to just click the option. Similarly, for surgeries, you have breast conservation, mastectomy, similar. So you need to structure this in a standard fashion. The majority of the queries should be structured. They should be user friendly, drop down menus, so that you should not take more than 5 minutes at a particular point of data entry. And this data should be readily analyzable using any software like SPSS or any survival analysis. We should be able to transfer the data. What we have done is we have divided our database into different modules: demographic module, clinical module, investigation module, treatment module, outcomes, and additional modules where you can create census, morbidity, mortality, discharge summaries, operation records. Everything is built into this software. You can generate these reports. This is a relational database where we have linked a broad general oncology database with organ specific database related to head and neck, gastroesophageal, sarcomas, gynae, breast. Each organ has got a specific database which is linked to the general database. Language we use in database is extremely important. You have to use standard medical language, either a mesh terms, ICD coding, standard staging. It should not be left like you see a file in a clinic. President may write breast cancer, CA breast, carcinoma breast, breast tumor, breast malignancy. There are myriad of terminologies which can be used, but you have to be very careful. It should be conformed to the international standards and use standard terminologies. Software requirements, you have various options. When we started 20 years back, we started with Access. We are working on Access and Excel. And there is a front end, there's a back end for the software storage. And you need to define what exactly you want on the front screen, what modules. So it should be user friendly. It will open 5. If you want to enter demographics, you just enter demographics. You want to enter histopathology, you just click investigation module, something like that. Quality control is extremely important because we are going to deal with multiple users. Chance of misuse, improper entries, corruption of files and loss of data, privacy and medical legal issues are extremely important. So you need to have a clear-cut data governance and management policies, data security and management policy, and data quality management policy. So these have to be built in when you are planning your database programs. So you need to have a team, a core members who look after these domains. So our idea to develop a database came to me sometime in 1995 when I joined as a faculty. In the initial phase, we started standardizing treatment protocols, streamlining case files entries, designs, proformas. We have at that time computers were a luxury. There was only one computer for the entire IRCH, only one. And we used to take permission. We have to give it in writing. I want to use the computer today after 6 o'clock. That was the situation. Now you see there are plenty of devices are there, but you are not optimally utilizing them. And what we did after finalizing the database, we retrospectively entered till 1993, and currently our program is ongoing. So entire clinical database where our patients are getting operated is totally computerized as of today. So this is few examples of proformas for disease-specific proformas. This is how it looks like. If you want to enter a new patient, click the first option. You want to make a discharge summary, you want to run a query, or print a record or summary something. If you want to enter a histopath, again you put a unique identification number. So these things will, this is just a general architecture of the database. Now I request Dr. Sunil to discuss the current management protocol of our database.
Thank you very much, sir. I think he has given a very good background. My job is to tell you that how exactly we are doing. And principles remain same, what was envisaged way back 1995. Maybe the modules have changed, maybe the computers have changed, the basic philosophy and principle remain the same. So the first question is that, who does it? And the answer is simple. The ownership resides with both the faculty and residents. It's a combined venture. And data entry and update, that's essentially a small team-based approach of one faculty or two faculty and 2 or 3 residents for each core area, what Dr. Dev has highlighted earlier. And it's entirely handled by clinical personnel. Computers are not touched by a single data entry operator because it's a purely clinical database, and if there has to be maintained a sanctity, it has to be done by the only clinical personnel. At the same time, since they are investing their time, so that cannot be stretched too far, and it has to be simple and goal directed. I'll show you the snapshot. Most of the entries are drop down based. Yes, there are some structured forms like operative findings also, but there are very few of them. Most of the, entries are drop down menu based. So for this purpose, each resident, when they join, they are allocated a core area. They will be working on that for next 2-3 years or so. And generally it happens that their thesis is also related to that. At the same time, whatever comes out of that, since they are investing their time and energy, the credit goes to them. Not only in doing the, stay in the department, many a times when they have left the department even after 15-20 years. So that gives an opportunity to them to learn how to design it at the first place wherever they are going, and also how to maintain that. So next comes the basic input and output mechanism. So it consists of 2 parts. One is the paper proforma part, and other is the digital format part. Because just to go for the first part, so we have a file to start with, and that the information will be transferred first to the proforma, which is purposely designed for that organ system. Once that is done, then comes the digital form, and there are 2 parts to again. One is the master operative database, for which every patient will be entered irrespective of the organ system, and the same database is linked to the organ-based databases as well. There are few standalone systems also, because now the numbers are growing day by day, as well as the areas are getting more specialized. Along with that, we also have surgical quality control database to monitor the morbidity and mortality, And for this, commonly two programs are being used. First is the access form, which was the original version. It's simply because most of us are so used to that. And the standalones are MS Excel version. Then we have the output. There are some day-to-day activities related to that. And what are these? Essentially, you can see there, this is the main operative database. On the left side, you can see most of them are having option menu. So you have to choose only one. So that leads to standardization. It's not according to our whims or fancy what to put in the entry. So you have to choose and you'll be forced to choose. On the right side, you can see the linked database, which is for morbidity and mortality for each area. And are you talking about output? On the left side, you can see this is the same report generated from the Access program for operative findings, and that will be transferred automatically. On the right side, you can see the discharge summary. So you don't have to type it again. All the fields, whatever they are taken up from the master database, and automatically they are just selected fields, and this will be generating the discharge summary as well. Going back to the same thing, these were the two things which are using day-to-day practice, but more important is the analysis part, because that is something which gives you the long-term experience and analysis. For that, you need to have interface or transportability to a analytical program like SPSS or Strata, which we are very familiar with. And then comes after establishing the how to update and maintain the quality. So every 6 months there is an update for the survival, because in oncology everything boils down to survival only. At the same time, to maintain the continuity as well as to weed out the incomplete entries, we have monthly and yearly surgical audit so that the entries are not haphazard or incomplete. 6 monthly morbidity and mortality audit is also there along with the anesthesia team in a combined fashion. One example is that analysis of histopathology after month or 2 monthly basis, because that gives you an opportunity to keep a tab on the treatment course of the patients. Someone who has not been planned, that at the same time you can actually call them and get into the system for treatment. At the same time, you have to keep a backup because you never trust the computer for the whole. Anytime it can just crash, and then for that reason we have to have a monthly backup. So essentially it gives an opportunity for the course correction. The bigger purpose is to keep it as a source of evidence generation, because it gives you an handy tool for quick and objective analysis by exporting it to analytics program. So essentially we have an opportunity to get our hand on a real world data, generating a real world evidence. No guesswork and no rough estimates. All the time we keep saying that in India numbers are our strength. Absolutely true. But at the same time, the rider is that has to be in a very organized and meaningful manner as well. Otherwise, these numbers don't mean anything. And then I'll just ask, tell you how that database is giving us opportunity, which is the common scenario for any resident to come to the faculty 2 days before the deadline that we have an abstract to send, and this is the situation. So the question is, what is the current status of smoker patients who were operated for lung cancer, T2 stays, who had a post-operative hospital stay more than 5 days? How do I do that? Answer is simple. Go to the lung cancer database, choose your relative fields for the query generation. On the right side, you can see what are the fields I have chosen: the size of the mass, post-operative hospital stay, and the status. Then I define for every parameter the criteria. The smoking should be yes, size of the mass should be more than 3 centimeters, and post-operative hospital stay should be more than 5 days. Here is the answer. You analyze it, transport it to SPSS, whatever factors or whatever the multivariate you want to run, the table is ready for you. That's all. Thank you very much. I'll call Dr. M.D. Ray to continue with the further discussion about the value of the databases as per different organ systems.
Good evening, everybody. So part of our team that looking after the peritoneal surface malignancy and genitourinary gynec cancer. So you know why we need that PSM and GGU database, any database like this. The simple answer is there. The data is the new gold, and the database is the gold mine. So that is the answer of this. So we look at the peritoneal surface malignancy. You know that peritoneal surface malignancy is upcoming in the branch of medicine and coming up for the last few decades. And this heterogeneous group of conditions and dynamic field keep changing this thing and not a standardized yet, and difficult to capture the data in the same platform. And that is the biggest challenge in the to acquire the PSM data. And genitourinary gynae malignancy, you all know that is the very much that increase incidence day by day, and that is 1.5 times more in the last decade. So we all know that is gradually increasing. And these are our these are common peritoneal surface malignancies cancer we look after here: the ovarian cancer, appendicular cancer, mesothelioma, colorectal cancer, gastric cancer, and few selected cases of sarcomatosis. And genitourinary cancer is an all normal cancer, starting from the CH cervix, endometrial cancer, the germ cell tumor of the ovary testis. Even we are looking after the kidney cancer and the bladder cancer. And penile cancer is a large number of patients with us in penile cancer. So these are the data collection. Already Dr. Sunil and sir mentioned about the basic things. These are the data collection. We have the specific proforma of that, organ and disease specific proforma. We capture all these things, pre-op, intra-op, immediate post-op data, and all the specific things there. You have just click on this, and it is very easier for us. So these are the different fields are there. You can see this like baseline characteristics, say management protocol. We know how to manage this thing, patient surgical parameters, perioperative complication, follow-up, and most importantly the audit, periodic audit of these things. So everywhere you can see this. These are the multiple fractions are there. So that we do one serially. And these are the simple proforma used for the collection of the ovarian cancer also, like one proforma we put this thing just for an example. So these are the Excel sheet kind of thing, like 60 columns are there. We have to pull from the higher stage number, patient names to operative rehabilitation, operative surgical note, post-op morbidity, histopath report, even in the follow-up. So many large column is there that you have to fill up on that to get this. These are our number, this thing 262 we have done till date in the CRS HIPIC patients. And commonly our patients are ovarian cancer, apart from this colorectal, appendicular cancer more common, and other cancer are very less, mesothelioma, sarcomatosis, even the stomach cancer. So these are even gynec cancer, the all common cancer are there. For the last 10 years, we are doing almost all gynec cancer there. So apart from this, the urinary cancer, that is bladder cancer and RCC also common in our city. So these are our publication that is most important because on the database why it is required. Sir told that is the medicine of this thing. So academic career. So that is our publication in this PSM and GGU data. Total ovarian cancer, our original article we are talking about, that is 25, and peritoneal surface malignancy 19, GGU 10, and molecular oncology we are working on that also, molecular oncology 4 paper, and abstract and awards. There are a total number of abstract present in the national and international forum, that is 41, and award won in international national conference around 8 in this particularly in this database. So these are a few publications I wanted to highlight. That is our important landmark publication on the groin dissection, because we have done almost 300 groin dissection with our self-designed technique, and there is no flap necrosis till date, and it has been published in different international journals. And this is for the upfront surgery, cytoactive surgery versus neoadjuvant chemotherapy. That is a very controversial issue in case of ovarian cancer and advanced ovarian cancer, that we have highlighted when to do the cytoactive surgery upfront, when you go for the NSCT. Apart from this, high alert zone is there, that is nerve sparing RPLN that is very commonly performed in the gynec cancer. So that we have published also that. And even apart from this, the facility and outcomes in the low and middle income country, how the CRS HIPIC to be performed, that also we share our experience to 32 patients in the World Journal of Surgical Oncology. So these are our molecular paper. So we are also fond of doing the molecular research also. This is the molecular linking of HIPIC in ovarian cancer. That is review article, and another also our results also published in Clinical Immunology Communication. So apart from this, you know that is the same answer is there. Why this data? Why you are talking about that? The gentleman says the right thing. Data is the new science. Big data holds the answer, and ultimately the data is the language of the power holders. So thank you very much. Next, Dr. Ashutosh to present the breast cancer data.
Thank you so much, sir. Very good afternoon to all. So I'm just giving the glimpse of breast cancer database here. So as you all know, currently the breast cancer is the biggest burden pertaining to cancer. So in India particularly, breast cancer accounts for 13.5% of total cancer burden and 10.6% of the death. And breast cancer replaces cervical cancer as the most common cancer, and because of that we need a specific and dedicated databases for the breast cancer. So in our department, basically we are maintaining breast cancer databases considering all these domains: demographic, clinical profiles and investigations, entire neoadjuvant treatment, pre and post surgery pathological details, surgical procedure details, followed by adjuvant treatment, follow-up, and most important, recurrence pattern and management. So this is the breast cancer database pro forma, where we entered or captures all the raw data and do the entry inside the databases. So why it's challenging? Because breast cancer is a multimodality management, there is a lot of dynamic fields like the introduction of molecular classification. There is a lot of changes in the TNM classification over last 2 decades, and there is the introductions of newer modalities like PET-CT scan, CT scan for the metastatic purposes, genetic profiling. Recently, we are more focusing on genetic profile, BRCA1, BRCA2, and other genes as well. Change in surgical practice. So we are de-escalating our surgical practice from radical mastectomy to currently breast conservative surgery, and from ALND to the focused lymph node dissections and SLNBs. And there is a lot of change in the neoadjuvant treatment because of the introductions of the targeted therapies and other molecules. So the entry in the database becomes a real challenge to modify the database from time to time and introduce all these entries in the database. So currently, we have entered 4,825 of the patient surgery, in which we have done the surgery till December 2020, out of which early breast cancer are 1,994, locally advanced breast cancer 2,510, metastatic breast cancer 2017, and upfront surgery were done in 2,800 patients, surgery of NSCT in 1,200 patients, and these are the separate entities. Bilateral breast cancer are almost 127, and geriatric breast cancer are 720. This is the trend over the 3 decades from 1992 over the 2021. So we are continuously increasing the rate of surgeries, and around 2017 and 18, it's crossed almost 400 surgeries per year for breast per se. And you can see the dip thereafter because of the COVID pandemic. Here in this graph, you can see the rates of early breast cancer, picking of early breast cancer and moving towards the breast conservative surgeries. So simultaneously, both are approaching. Initially, EBCs were 20 to 30%, but right now we are seeing almost 40 to 50% early breast cancer, and in same way we are doing breast conservative surgeries. So breast cancer database, it's one of the largest breast cancer database in India. We have produced almost 126 publications in index journals, out of which 26 publications in collaboration with other institutes. And we have done almost 250 plus presentations and publications and more than 30 book chapters. With the help of our database, there are the institute, Indian ICGA, Indian Cancer Genomic Atlas, MSKCC, Amity University, Jamia Islamia, and out of these Indian institutes, couple of, or I would say a dozen of PhD students are doing jobs in the America and other foreign countries. And these are some highlights with the help or in coordination with the interdepartmental work, profile of pathogenic mutations and evaluation of germline genetic testing in breast cancer. And we have seen there almost 80% of the patients we have screened over the period of year were positive for BRCA genes. Similarly, this is a landmark paper, sentinel lymph node biopsy assessment using imprint cytology. And here we see with the blue dye technique and imprint cytology, almost 98% accuracy. So these are the journals and these basic science research papers. And I will call Dr. Jyoti for. Thank you.
A very good afternoon. I'm presenting the oral cancer database. The Indian contribution to global burden in oral cancer is highest, and it according to the Globocan 2020, it accounts to 36% in incidence and 42% in mortality. The cancer of the lip and oral cavity is the most common amongst the Indian males. So this outlines the need for an oral cancer database. Not with proud, but we can say that it is an Indian cancer because of the different risk profile, the patterns of presentation, the use of smokeless tobacco, and poor nutrition, and the risk factors are different as compared to the West. So we need to have our own data so that we can generate guidelines and protocols to cater our population and improve their outcomes. But when I say a robust database is required, it does not come without challenges. Oral cavity itself is a small area, but it covers almost 8 subsites. and there is a wide area of section and reconstruction options. So entry with the uniformity and consistency is required over the years with a number of new people added every year. The database captures all the information starting from the epidemiology, symptomatology and risk factors, preoperative treatment, operative details, postoperative course, pathology, adjuvant treatment, and follow-up. This is the proforma that we use in our oral cancer patients, and it is filled in all the patients and attached in all the files. After this, it is added. Then this is digitally converted into an Excel sheet. And here we can see that a large number of domains, which is just a glimpse of it. And we have more than over 80 fields have to be filled for every patient. And this is the complexity of the proformas that we need to fill. So far, we have entered around 1,921 patients from 92 to 2018. And there has been a consistent increase in the number of patients oral cancer, only except that's a dip in because of the pandemic, and it's again increasing. The subsite distribution, as again, this data is important because we need to see the trends in the subsites involved in oral cancer as compared to the West. Initially, it was the tongue, the alveobuccal complex, which was more common in Indian population, but now there's a change in the trend towards the tongue. So this is possible only if we have a good database and we can compare it from the Western literature. Because of this database, multiple research collaboration could be done with different departments within AIIMS. So far, we have 96 publications in index journals and 36 papers with collaborative research on basic sciences in high impact journals. We have around 24 presentations, including papers and posters, and around 4 awards received in national and international conferences. I will just highlight some of the few papers that has been published in the reputed journals. So one of this is an epidemiological model to find out the factors associated with nodal involvement, and here it is data of 945 patients which was used for developing a regression model, and another 200 patients were further used for validation of this model. So this was only possible because of maintaining a good quality database. Another, this is again pertaining to our own Indian patients. When we have a lot of burden of the patients and we are facing a problem with the dates. So we are trying to find the new modalities that we can help with preventing the disease progression. Similarly, then we have another papers that have large databases that has been published and depicting the spectrum of patients in Indian patients. So again, a review of 15 years experience at in our center. Thank you. Now invite Dr. Sandeep sir to.
Dr. Jyoti. Good afternoon, everyone. As we all know that gastrointestinal cancer comprises of various subsites. Upper GI cancer includes esophageal, gastric, and small intestinal carcinoma. Lower GI includes colonic and rectal carcinomas, and other subsites like hepatic, pancreatic, and biliary radical carcinoma. These subsites have different treatment protocols, and the incidence of all these subsites are increasing in India. So there is a need to maintain a comprehensive database to analyze the treatment protocol outcome of these subsites. According to the latest Globocount 2020 data, GI cancer from esophagus to anal canal comprises second most common cancer among males as well as females. As these GI cancer has different subsets, so every subsite has a different treatment protocol. So we have to maintain a different database with different entry units, so that the each subsites carries a different data protocol or treatment protocol which can be captured. So this is the carcinoma gallbladder cancer. This is the proforma, and it has around 80 data entry units. Carcinoma pancreas has around 180 data entry units. For colorectal cancer, we have around 200 units which can be entered. These are the proforma which can be transferred to the Excel sheet or Access format sheets. In the Excel sheet or Access format sheet, we can see that the most of the entries are in the drop down menu, which is very easy to enter, and it makes a data an objective database, which can be analyzed very easily. Similarly, this is for gastric cancer database. In our database for the last 2 decades, we have around 1800 cases in GI cancer database, out of which colorectal cancer is the most common, which carries around 1100 cases, and it comprises around 40% of the total GI cancer data load. Second most cancer is esophageal cancer, which comprises around 20% of the total cancer load. These are the year-wise distribution of the last decade of various subsites of the GI data. From this database, we have done around 82 publications and 14 research publications with collaboration of the various departments of the institute as well as outside institute. Our SRs have won 5 prizes from using this database in various conferences. These are the important publications. First publication is recently published in JCO Global Oncology. It is the first publication from India highlighting the demographic and clinical profile of such large numbers of patients. One of the important outcome of this publication is that it shows that young colorectal cancer patients peaks at decades earlier as compared to their Western counterparts. Another publication which appeared in Annals of Hepatopancreatic Biliary Surgery. First of all, we published our outcomes of end-to-side pancreatic gastrostomy. These are the other publications which appeared in various good journals. These are the abstract which has been published in various journals and presented in various conferences. Now I will invite Dr. Naveen to present thoracic data.
Good afternoon. Good afternoon to all, and thanks to Dr. Sandhi. So I'll be presenting a thoracic database. So we know that the lung cancer is one of the most common cancer in worldwide, and it's a leading cause of cancer-related death. And in India, if we talk about India, the lung cancer accounts almost 6% of all cancers and 8% cancer-related death. If we particularly talk about the India, there are only few centers have a surgical thoracic database with multi-model management. So there is a need to capture all the data related to thoracic cancers. So if we talk about the thoracic cancer, there are various subsites, right? That includes lung cancer. We talk about lung cancer, it's a wide variety, including non-small cell, small cell, carcinoids, and pulmonary sarcomas. Mediastinal tumors like thymomas, germ cell tumors, and sarcomas. Chest wall tumors, like there are various subtypes of chest wall tumors that are based on subsites and as well as on histologies, and pulmonary metastasis. So majority of the pulmonary metastatic patients were treated with a curative intent that were metastasized from the other subsites like colon and renal cell carcinoma and sarcomas. This is our general thoracic cancer database. We have captured all the informations like clinical details, examination findings, and investigations. In investigations, we have captured about all the investigations like bronchoscopy, endoscopies, CT scans, surgical details that includes anesthesia details, perioperative and post-operative outcomes, histopathological outcomes, and as well as adjuvant and follow-up of the patients. This is lung cancer database. In addition to that general thoracic cancer database, we are also capturing the nodal status of the patients in lung cancer database. This is how we look the lung cancer database. This is in the Access format. This is our chest wall tumor, which is in the Excel format. So if we talk about the whole number, the thoracic database includes 764 patients, and among them 274 are lung cancer, 210 are mediastinal tumors, chest wall tumors are 188, and pulmonary metastasis are 92. So if we talk about the outcomes of this thoracic database, total 37 publications have been published in various national and international journals, and among them 6 are translational research. 14 papers have been published and presented in national and international conferences. 5 residents got prizes, and 2 residents got travel scholarships, and 1 patient got international preceptorship based on this data. These are the few important studies being published from the thoracic database. One of the important was the neoadjuvant chemotherapy followed by surgery, because we have very limited data of neoadjuvant chemotherapy in lung cancer patients. And second one is the primary lung cancer with chest wall involvement, which is not common in lung cancer patients. This is another papers we have published. Upper one is based on the translation research, and second one is the randomized control trial. And this is the list of all of papers and posters been published and presented in various conferences. Now I would invite Dr. Jyotishman for soft tissue sarcoma.
Good evening, everyone. Soft tissue sarcoma, as you know, it's a rare and heterogeneous tumor with less than 1% adult cancers. It has diverse anatomical sites, more than 50 histological variants, and most publications are less than 100 to 200. Hence, there's a need for STS database for long-term outcomes. As you can see, this is also a similar type of proforma for soft tissue sarcoma database. Capture the various fields in a systematic way. The number of cases, you can see that the consistently increasing number of cases throughout these years, which now reach around more than 1,200 cases. So this tumors arise from the either extremity or non-extremity. In extremity, and more than 600 patients. In non-extremity, around 400 patients with various subsites. Histologically, the synovial and undifferentiated are the most common types we have encountered. I have published around more than 30 publications in index journals and with abstracts of around 13 and awards and prizes of 3. And these are some of the important publications from our department with collaboration. Thank you. I request Dr. Babul.
A very good evening to all of you. I shall be showcasing our departmental databases on uncommon cancers. Uncommon cancers have low incidence and generally appear in the published literature in the form of case reports and case series. This is because it is difficult to gather adequate number of patients in a finite time period to conduct any meaningful research. Our databases help in collecting comprehensive data over a long period of time in a structured format, and in turn help us in generating high quality evidence pertaining to clinical spectrum, treatment patterns, outcomes, and survival. This eventually helps us in formulating treatment strategies for treating these cancers. The uncommon cancer databases which are maintained by a department are that on thyroid cancer, orbital tumors, skin cancer, and salivary gland cancers. There's one thing. So yeah, the thyroid cancer in itself is not a rare disease, but what is uncommon about the thyroid cancer database which we maintain in our department is that it mainly comprises of locally advanced and recurrent reoperative cases. We have a total of 467 cases in the thyroid cancer database, of which one slide is not coming. Yeah. So yeah. There are 467 cases in the database, of which 1/3 are reoperative nature. A manuscript, the reoperative cases are 157. A manuscript of the reoperative thyroid cancers has already been prepared and is currently under review, and once published, it will be the largest such experience in world literature. In the skin cancer database, a total of 326 patients are there, of which 66 are that of malignant melanoma, and the rest are that of non-melanotic skin cancers. Orbital tumor database is another database which we are proud of. It comprises of locally advanced and recurrent orbital tumors, comprises of a total of 102 cases. The manuscript is under preparation, and once published, again, it will be the highest such experience in the published literature. Salivary gland tumors, there are a total of 116 cases in the database, of which 90 are that of parotid, 18 of submandibular, 1 is that of sublingual, and 7 of minor salivary gland. They are different modules in the thyroid cancer database, that of demography, symptoms and examination, investigations, previous treatment details, management details, morbidity, and that on surveillance and survival. This is a snapshot of the thyroid cancer database. There are total of around there's total of 152 fields for a single patient in this database. The database is therefore very comprehensive. This is a snapshot of the Orbital database. There are around 78 fields in this database and is again comprehensive. The skin cancer database, this is a proforma for entering the data in the skin cancer database. After entering in the proforma, the fields are entered in the Computerized database. These are stats which I already told you about. These are some of the publications. An original article on sebaceous cell carcinoma has been published using the Orbital cancer database, the journal Orbit. This is a single center experience on skin cancers, the Indian experience, published in the Indian Journal of Cancer. Thank you. I would like Dr. Dev for.
Thank you, Baul. I think we'll wind up the presentation. It's almost 2 decades journey. So this is just a glimpse of what we have done in the last 20 years. So just to summarize our entire journey, now we are entering the field of multi-omics. We were just having a chat with Dr. Subrata Sinha. We are into proteomics, genomics, lipidomics. So all this research in oncology is irrelevant if you don't have a good clinical database. It has no meaning. So that is the importance of database even now. 20 years back we started, but now it is a gold mine. So any new genetic marker or molecular marker you want to test, so you have a ready-made sample available of 13,000 patients. So this is how you need to integrate the platforms in any top-notch cancer center. So you have a multi-omics platform doing translational research, needs to be linked with the clinical database. So that is where you get meaningful outcomes, the real role of multi-omics, how much impact it is making. Unless you have a clinical database, entire these labs, this investment, everything is going to be waste. I will just give you 3 research scenarios. I've been interacting for the last 1 year, Dr. Sandeep Mathur, Dr. Shipra from pathology, Atul Batra from medical oncology, Dr. D.N. Sharma. They just come out and ask, we want 50 patients, breast cancer, TNBC, obese patients. He wants to do a research on breast cancer and obesity. Dr. Shipra wanted thyroid cancers. I want 50 bad thyroid cancers. I want to see some marker. Dr. Atul is doing on obese, Dr. Sandeep Mathur is doing on TNBC. So it took us just 1 hour to give the wish list. I want BMI of this, I want this patient, I want this patient. You have the data, including follow-up, available within 10-15 minutes. This can be generated. So that is the power of a database. You can validate your new biomarkers, you can define clinical data set requirements, and data can be provided in a short time. Just to sum up, this is what we could gather in last 20 years. We have a database of 13,000, now it's touching 14,000 patients. Deliberately, we are taking only patients whom we are operating and who are getting the complete treatment of IRCA. There's no point taking patients from OPD who are half treated, who are not coming for follow-up. You gather a lot of data which is meaningless. So this is deliberately done. So we are including only patients who are getting the complete treatment done, who are getting operated at our center, so that the data will be meaningful. Otherwise, we must have treated maybe 50,000, 60,000 patients, but the quality is important. Publication part, this is, I think, the proof of pudding lies in eating. All our residents and our faculty, as of now, the total number of publications is touching 450 in the last 20 years. This was possible only because of the database, only because of the database. Just to conclude our presentation, database is an essential requirement for any academic practice, not only AIIMS. It should become a habit for any clinician, whether you are in private practice or you are in academic center. Because you are in the era of EBM, and quality and systematic data collection is extremely important. It will boost the academics, research and publications of the institution. Clinicians should take the lead. Don't wait for computer facilities. Some multinational, some Ernst Young, some Infosys will come and do it for you. I'm watching everything for the last 30 years. Okay, so you have to take the lead. Commitment and teamwork. It is a very difficult journey, long journey. So it's very easy to get idea, start some database, then it will fizzle out. Maintaining it for 20 years is a challenge. So you need to have a very big commitment, include everybody. Everybody should be a stakeholder, including faculty and residents. Then it will become a habit, and everybody will get a benefit. Every resident will get a benefit. They get a publication, they get their thesis done, they update the data. So now it has become a lot like a routine activity of the department. It is not a separate standalone project. So then only it will work. Otherwise, creating fancy forms, IT experts will give you a lot of software, nothing will come out of it unless the whole department is committed. And this, of course, will lead to our transition from the real EBM, ego-based medicine, to evidence-based medicine. This is our core team. We started our project. Dr. Sunil was there at that time. And I would like to give credit to Dr. Srinivas, Dr. Madhav, Dr. Sonal. These were brilliant residents who were working with me when this idea came in 95. So we used to sit with them every weekend to create these databases. It took us 2 years. So this is the family of surgical oncology faculty and residents. Everybody is a stakeholder. And I would like to thank, this is not surgical oncology database. This is a cancer center database. So everybody has access, including anesthesia, medical oncology, radiation oncology. Anybody wants, our database is open. So for collaboration and for publication. So this would not have been possible without the cooperation of all the specialties involved in the patient's management. We only did the job of collecting the data. But this is a collective effort and it can be utilized. And we acknowledge every department in every publication. So these are the small issues. Sometimes you get lost because who gets the credit? Okay, that is why we don't progress. So every member, suppose a senior resident works 20 years back in a sarcoma, we make sure his name is there in the current publication. So we need to be transparent, accountable, and give credit to the entire team members. Then only these kind of projects will work. So with that, I would like to conclude our presentation. I think we are just in time. That's the end of presentation. We can take some comments or questions or any suggestions. Dr. Subrata Sinha sir is there. Dr. Sushma, Dr. Amlesh is here.
Example data.
Yes. So that is actually, we started the proposal for tissue bank, creating a tissue bank at NCI, because in IRCH it was logistically not feasible. So we have a plan proposal for translational research at NCI. The whole plan is conceived. It is ready. We need to execute. It got delayed because of the COVID project. So once it is created, we are planning a comprehensive research plan at NCI, which will link the tissue bank, the clinical databases, and all the basic research. So that bridge is extremely essential. You're absolutely right. Sure.
I can say that it's a very wonderful thing, and as Ish was saying, that the linkage, I hope it has a flexibility to expand and accumulate, and link itself with, let us say, other databases like through maybe your UHID, through ultimately imaging, biorepositories, and maybe expand your, let me say, your histopathology reporting towards even regular molecular classification, because very soon, I mean, right now, of course, ideally we should be using that as a standard of care. So a certain amount of flexibility, I hope you've incorporated into the architecture, and I'm sure that would be there. But it's a very wonderful idea that you had thought of it and nurtured it for so long, and it's done so.
Thank you, sir. So the beauty of the database is it's a modular system. It can be always scaled up, it can be modified, and you can attach extra modules. Like if you want to integrate radiomics, if you want to include genomics, it is possible. So that is why these are called relational databases. Structure is modular, it can be scaled up. They are compatible with all the current databases which are being used for radiology or pathology. So that linkage can be done. But everybody has to join. They have to start somewhere. Absolutely, absolutely. It is the mindset. The, the biggest block is this. So otherwise, sky is the limit, and it will be win-win for everyone. Everyone. That much I can assure. Any other comments or yes, Dr. Pranay?
So, sir, at this point, I want to thank you because in 2014, when I got first breast cancer project, I discussed with Dr. Julka and you really helped me out. And we have been collecting samples as to Sir Amlesh said, sir, we have been preserving some of the samples which we have collected from Dev Sir Koti, and we have made a small repository for whatever some of the cases which we have done genomic sequencing. But the idea was been already been under discussion that we are trying to develop a bigger repository with all association with all the clinical and imaging parameters. Thank you so much.
We should do it. Actually, we are wasting time. I think we are already late. So we need to push fast. So these things are doable, and it is. I think integration is very easy. There's lots of things can be done. I think we have to move fast, especially linkage with radiology, as Dr. Subhadrasin has said, pathology, the basic sciences. So that I think you see most of the platforms are ready. Don't have to reinvent the wheel. Platforms are ready. We just need to. All right, there are no more questions. We would like to thank everybody for attending this CGR. Thank you very much.